Welcome everyone. In the next few minutes, I would like to show you the progress I made in the past 9 months with my PhD thesis, which is physical activity in inflammatory bowel disease. My name is Emese Kasznár. I'm a medical doctor, and I work at Translational Pediatric Institute. My mission is to encourage IBD patients to exercise more, to reduce their disease burden. And for this, my vision is to improve the management and quality of life of IBD patients. I have 3 projects investigating the physical activity in inflammatory bowel disease. The first one is a systematic review and meta-analysis, which investigates the disease activity and quality of life before and after exercise intervention in inflammatory bowel disease. Some data suggest that IBD patients tend to have decreased physical activity, bone mineral density. They can have anxiety and depression and also decreased muscle mass. But in 2022, there was a meta-analysis which showed that regular physical activity can have a beneficial effect on the bone mineral density, physical activity, and quality of life. So we would like to analyze the effects of physical exercise on disease activity and quality of life. For this, our clinical question, does exercise intervention affect disease activity and quality of life in IBD patients? The population will be the IBD patients, children and adults as well. And we have 2 primary outcomes, disease activity index and quality of life. And we also have 5 more secondary outcomes. In this first plot, you can see the health-related quality of life. Which means that with some questionnaires, disease-specific questionnaires, they search the quality of life of the patients, and higher scores means better quality of life. We could include 9 studies. In the first 4, we could not separate the diseases, so it is IBD patients. In the next, we can see the Crohn's disease patients, and the last one is ulcerative colitis patients. The heterogeneity was high because of the different scales. We used IMPACT 3, IBDQ, and the short version of IBDQ. We could include 169 patients. As you can see, we used SMD, and the effect was 0.55, which is a moderate effect, statistically significant, and we found this clinically relevant as well. In this slide, you can see the subscales of health-related quality of life. I put them in descending order, so the biggest change was in systemic quality of life, which measures systemic symptoms, quality of the sleep of the patients, or fever, and as you can see, it had the SMD of 0.59. Next one is emotional subscale, which measured the patient's depression, anxiety, and as you can see, the SMD was 0.53. On the social scale, the SMD was 0.44, and the bowel scale was the smallest, 0.34. The reason for this is that most of the studies included patients who were already in remission, so they did not have bowel symptoms or just a few. In this next figure, you can see the Crohn's disease activity score. We could include 2 pediatric studies and 10 adult ones. This measures the patient's disease activity by their symptoms and laboratory measurements. And as you can see, the heterogeneity was high. We could include 216 patients, and the SMD was minus 0.21, which means that after the intervention, their disease activity score decreased, so their symptoms improved. This was not statistically significant nor clinically relevant, but the reason for this, as you can see, half of the studies only included patients who were already in remission. On this next slide, you can see the ulcerative colitis patients' disease activity scores. We could include 3 pediatric studies and 5 adult ones. The heterogeneity was high because of the different scales of measurements. We could include 105 patients, and the SMD was minus 0.23, which is also statistically not significant nor clinically relevant for the same reasons as I mentioned before. On this next slide, you can see the fecal calprotectin, which measures the inflammation in the bowel system. In IBD under 250 milligram per kilogram, it suggests the mucosa is healing. We could include 2 pediatric and 2 adult studies. As you can see, 3 of these studies included patients who were already in remission, and the delta mean was not as big as in the study where they included patients who were in active disease status and in remission. As you can see there in the first study, at the Schaeffer study, the delta mean was minus 450. So we can see a tendency that in the active disease status, the fecal calprotectin can decrease. The heterogeneity was high here also. We could include 73 patients, and the delta mean was minus 101, which is clinically not relevant nor statistically significant. In this table, you can see our secondary outcomes. As you can see, only in 2 outcomes, the lean body mass and aerobic fitness, was a statistical significance, but we cannot see any clinical relevance, but we saw a tendency towards improvement in all of our outcomes. So the strength of our study, that the changes were compared to the baseline measurements in order to demonstrate the benefits of the exercise at an individual patient level, and patients with IBD were analyzed separately according to disease activity. The limitations that the interventions were different in times, in type of, so it was different in time and length and type and supervision, and we could not analyze all of our outcomes based on age group. The conclusion is that regular physical activity improves quality of life, and there's also a tendency for disease activity scores to decrease even in patients who are in remission. Implication for research, and that patients should be advised to engage in more physical activities, and implication for research that we should include patients with active disease status and children as well. I'm writing my manuscript right now, and to jump to the second project, which is compare the physical activity between inflammatory bowel disease patients and healthy control. As I mentioned before, there are some data that suggest that patients tend to be less active physically, not just in active disease status, but in remission as well. And it is a problem because reduced physical activity can lead to metabolic syndrome, osteoporosis, and sarcopenia. And IBD's prevalence in 2019 was 4.9 million worldwide, and it is increasing. So we would like to compare the physical activity of healthy population and IBD patients. We use the PECO framework, and we have 4 primary outcomes and 5 more secondary outcomes. I'm finished with the data extraction, and I'm waiting for forest plots. And the third project is investigating the effect of structured physical exercise in children with Crohn's disease. This will be a protocol for international randomized clinical trial. In pediatric Crohn's disease, the first-line therapy is exclusive enteral nutrition, which is a specialized liquid formula which they take for 6 to 8 weeks. We have data on the improvement of lean body mass and bone mineral density during exclusive enteral nutrition, but we do not know the effect on muscles. We know that sarcopenia, which is decreased muscle mass and function, is a bad prognostic factor for the disease, and 1/3 of adult patients have sarcopenia. So we would like to see the effect of structured physical exercise on prevention and treatment of sarcopenia in children. So in summary, I have 3 ongoing projects that are investigating the effects of physical exercise in inflammatory bowel disease. And I would like to close with Carl Sagan's words, somewhere something incredible is waiting to be known. Thank you.
Thank you very much. Great presentation. So I was just wondering, are you sure that the causal relationship is that someone has do more physical activity, some patients do more physical activity, then they will have a better quality of life? Is it not possible that it's opposite way around? If some patient has better quality of life, they will move more and exercise more than the others?
Based on our study, no, because it was a before-after study. So they measured the quality of life before the exercise intervention, and there was a baseline measurement. and they introduced them to a 12 or 8 weeks exercise intervention and measured the quality of life after this exercise intervention, and they showed they improved. In the 2022 meta-analysis, they compared to healthy controls, so not IBD patients, and to maybe answer this question, that in healthy people there was not as big of a change as in IBD patients.
Yes, but if you have, I don't know, 100 patients and you ask them to do more exercise, if someone is really sick, he or she cannot start the intervention, right? So they were excluded, or they were also included and kept analyzed in these kind of studies.
Yes, thank you. Most of the studies, as you saw, only included patients who were in remission, maybe for this specific reason, that they thought that patients who are in active disease status cannot exercise. But in some studies, they included patients who were willing to exercise more, even if they had active disease. So that means they had diarrhea 2 or 3 times a day or more, depending on their disease activity. But I do not know a study where they included patients where there was a really high disease activity status. So they only included those who were in moderate and they could do the exercises.
Because then kind of selection bias can be there, right? That can cause some observed change.
Yes,
There.
yes, definitely.
Thank you.
If I may, I would have one question. For your second and third topic, how would you define the sarcopenia? Because there are many definitions, so which one you will use?
Thank you for your question. In adult population, there is a definition for sarcopenia, which is something like that 2 SDs from deviation from the normal range, but sadly in pediatric population, there is no normal range. So,
and also that has to be established from healthy population, so you have to establish your 2 SD from standard deviation.
Yes.
Or then you can use the one that was applied in geriatric, but what is exactly the validity in IBD patients, especially the pediatrics one?
So we do not know the exact number. We would like in our third project. Now in our practice, we are measuring IBD patients with an in-body machine, and on the in-body machine, it measures the muscle mass as well, or the lean body mass, and there is a normal and a decreased range, and we would like to investigate on which data they based these ranges. So that's our first problem. Yes, we do not know which is decreased muscle mass, but now we are also doing another project where we are measuring 100 healthy children and measuring their muscle strength. So we will have a normal range, and we will see if how the IBD patient's muscle strength deviates from those.
Also, currently in IBD population for sarcopenia, the novel diagnostic treatment is the options is the ultrasonography. Are you considering the ultrasonography in your project?
We are not, because it's not that available to do with every patient, and also we do not have. We should do it with healthy population as well, than to compare it to.
Thank you very much.
Thank you.
Thank you for your presentation. I have 2 questions regarding the calprotectin outcome. You had 4 studies, 2 of them in adults patients and 2 of them in children. Interestingly, like in the children, the levels were really high, like 300 and 700, and the adults were like around 60. So what's the reason behind that? And the second question, the adults' calprotectin level was increased after the intervention compared to the children where it decreased.
Thank you for your questions. To answer the first one, in the pediatric studies, as I mentioned, the first one included patients who were in active disease status as well, so they can have higher calprotectin. I will jump back to the plot. So here, You can see that in the first study, where was the biggest change, and they started from the highest calprotectin score, there were children who were in active disease status, and that's the reason for that. And for the second question, in the Q study, there was a patient who relapsed during the intervention, so that's the reason for the increased calprotectin.
And what's the normal level of calprotectin?
For a healthy person under 50.
So isn't the last study considered normal level?
Yeah.
Okay. So, and it was increased after the intervention?
Because of that one
Because of
patient.
okay.
As you can see, we could only include 12 patients,
Yeah.
so it was not many, but one patient's calprotectin score worsened
Right.
the mean.